All right, Dr. Shah, you may now begin.
All right, hello everyone. Thank you guys for tuning in. My name is Sanket Shah. I'm an ophthalmologist in Fresno, California, in the USA. Today, I wanted to talk to everyone about planning phacoemulsification for the best outcomes. We're going to review some biometry basics and surgical strategies for complex cases. I'm looking forward to interacting with everyone as well as taking some questions, and we can go through some answers and discussion towards the end. All right. So accurate biometry is the cornerstone of successful phaco emulsification, and we want to minimize as many refractive surprises as possible. So today I want to talk about the critical variables involved in obtaining precise IOL power calculations. So axial length is our primary determinant. This is about 70% of the variability when it comes to our IOL powers. So it is the most important variable we have. An error as small as zero point 0.1 millimeters can lead to a large refractive error change of even a quarter diopter. Modern biometers do offer superior accuracy compared to our former immersion or contact ultrasound biometers. When we get our biometry, we want to make sure we have good data. Good data in means good data out. And so, depending on the biometer you have, it can have a signal to noise ratio or a standard deviation and image quality. These will let you know if we obtained sound biometry with reliable measurements or if we need to repeat the scan. The second most powerful item we want to examine is the corneal power. This determines the refractive power of the anterior corneal surface and a large portion of the remainder of our power in calculating the IOL. Having accurate keratometry, you'll hear me call them Ks, is absolutely vital for getting the spherical power of the IOL, and getting the axis correct is vital to getting toric lens calculations lined up correctly. When we're measuring these values, it's very important to remember that there is anterior and posterior corneal astigmatism, and we need to consider both of these to obtain the best results possible. Making sure that we have a correct axis of astigmatism is going to be paramount for correcting the astigmatism using toric intraocular lenses. The next variable is the anterior chamber depth. This is very effective in helping us determine the effective lens position after surgery. The actual value is the distance from the corneal epithelium to the anterior lens capsule. So variations in anterior chamber depth can have a very strong impact on these refractive outcomes, especially when it comes to short or long eyes, because it helps us determine, is the extreme in axial length also represented in the anterior segment of the eye, or is there a normal anterior segment with a very short or long posterior segment of the eye? The newer formulas do incorporate the anterior chamber depth more effectively to help us refine the power. The white to white diameter, this is the horizontal diameter from the limbus to the limbus. And we use these in many different calculations, including our lens calculations, but we also use them to help us size anterior chamber IOLs, capsular tension rings, phakic IOLs, and sulcus fixated lenses. This value helps give us an estimation of the ciliary sulcus, which is not really possible for us to measure directly with our modern biometers. The next variable is the lens thickness, and this plays an important role in the intraocular lens calculations because that can correlate with the age of the patient as well as the cataract severity. In people who have larger cataracts, specifically a thicker lens, this can actually affect, it can reduce the effective anterior chamber depth. And that helps us determine where will the IOL sit in relation to the cornea after surgery is done. And lastly, we have the central corneal pachymetry. This gives us an idea of the corneal health. We don't use it directly, but it is subtracted from the anterior chamber depth to give us an aqueous depth, which we'll get into more throughout this presentation as to how that can help us plan for surgery. It's important to show you in a patient who has corneal edema or Fuchs, a decompensated cornea. It helps us understand that exact value moving forward. Okay, so now that we have all the variables set, what do we do with them? We have many different calculations and formulas, and that was a very common question that was submitted prior to today is how do we choose the best formula? There's so many. And so it's important to know how we got to each formula and where did we start from. So the first generation formulas, the SRKT, Holiday 1, these rely on a regression analysis of data. As we move forward, we developed second generation formulas, the Haggis, L, Hoffer Q, the Olson. These incorporated more biometric data and serve very well for many lens calculations. But as we move forward into third generation formulas, we use ray tracing, artificial intelligence, and just vastly greater data sets because over time we were able to collect so much more data. And these formulas are the Barrett Universal, Kane, Evo, and these are vastly used. And then there's also other formulas for post-refractive eyes, which we'll get into a little later. For example, there's the Shamus formula. There's also many different online calculators. So if your biometer does not have a fully integrated suite where you can use any formula, many of these are available online where you can manually enter all of your information and still get the best possible calculations for your patients, even if you don't have access through your biometer. So how do we choose which formula to use? Now we know all the different generations, and you might ask me, should I just use the newest one? There's still ways to choose between those formulas. And we want to know the data and the results on each formula and which ones they are good for and which ones they might not be ideal for. So some formulas will be better for short eyes, some will be better for long eyes. You want to use certain formulas for post-refractive eyes. Typically, a lot of people will simply use whichever formula is most easily accessible on their biometer. I would strongly encourage you to look at 2 to 3 formulas if possible and compare their outcomes. And that can help you determine, you can have more um, assurance that the lens you've chosen is going to have a better outcome for that patient. I personally use a software that shows me 3 formulas for every patient so I can compare and contrast and help me decide where I'm going to choose the lens. This will also help you develop experience and comfort with more than one formula. It's very easy to pigeonhole yourself into using one formula for 1,000 cases. And now for your next case, you might say, I only have 3 eyes worth of data with these 2 formulas and 1,000 eyes with this other formula. I'm just going to stick with the other formula. When you're having a complex case, it behooves you to just double check. Look at other formulas that you might not look at and just helps you feel more comfortable in the lens you're choosing. As I mentioned with the third generation formulas, we have a much wider range of axial lengths that have better accuracy simply because the amount of data collected has increased over time. So let's dive right into it. I have 3 cases to present to you. I think they're all pretty unique. They're all patients that I've had in my clinic and in my short tenure as a practicing ophthalmologist. And I welcome questions. We'll have some interactive questions as well. So the first case we have is a patient with high myopia who also has a staphyloma. This is a 45-year-old gentleman. He presented to the clinic. He had a -17 diopter prescription. He was very young, but he did have posterior subcapsular cataracts. On his biometry, his axial length was 32.33 millimeters in one eye, and that eye's Ks were 39.55 and 41.23. He has not had any prior refractive surgery. So I'm going to go through many questions that I'd like to address with this case. We'll have some interactive ones, and then we'll go through all the answers together. But I'd like you guys to spend some time thinking about these, and if possible, we have the Q&A, which you can submit answers you might think to these questions. So again, we have a very large eye. This is high myopia. So, which IOL formula should I choose in this case? What has the best data with high myopia? And in cases of high myopia, we see a lot of patients who get LASIK. So, what if this patient was post LASIK? What formula would I consider then to have some of the best outcomes? So, that's question one, and we'll have a poll about that in just a second. Question two is when I'm addressing a patient with high myopia, what could go wrong and what might make things difficult for me during surgery and post-operatively? Now we're planning surgery. Are there any anatomical risks to this patient with high myopia, in the case I presented earlier, that would affect what lens we're going to choose? And are there specific lenses that might be better or worse for this patient? Some patients come in for refractive consults. They might want some advanced technology lenses. Is this a patient I can use any advanced technology lens in, or does it require a little more thought to outline which lenses might be better for this patient and which lenses might actually make him upset? So let's get into that first poll. Let's see, what formula should we use in this high myopic eye? Give you guys about a minute to just get your answers in there. And this is his actual biometry that was screenshotted from our Argos. Okay, this is great. I like to see results like this in questions. It's a very broad split. So we have 24% answering A, Hoffer Q, 20% answering B, Haggis, 39% answering C, Barrett, and 16% answering D, Holiday 1. This gives us a lot of points to discuss. So in this example, we have a patient with very high myopia. So the Holiday 1 formula by itself is known to have errors with high myopic patients, and there is a Wayne-Koch adjustment that we can apply to the axial length to subsequently then adjust the Holiday 1 formula to give us better outcomes. So in this case, where I just want to choose the formula, if I want a straightforward, easy formula with good data on its own, I'm going to skip that answer since it does not have the adjustment incorporated. The first two answers, Hoffer Q and Haggis, are some of our earlier generation formulas. They have good data. They have good data with shorter eyes compared to longer eyes. However, answer C, the Barrett formula, has some of the best data in high myopic eyes for having outcomes very close. So the plurality of you answered Barrett, and I would agree with that choice. Let me see if I can advance. There we go. And so in this case of a high myopic eye, I would choose the Barrett formula as it's giving me some of the best data. The Barrett also has a true K formula. This would be for a post myopic LASIK patient. This would give us a much better outcome. There's also an Asker's formula that you can use on their website, but both of these are freely available online. And in my experience, the Barrett True K is just easier for me to use. There's less data I need to collect and input to still get similar outcomes. We mentioned that we want to consider intraoperative and postoperative difficulties. So one thing we see quite often in high myopic eyes is lens iris diaphragm retropulsion syndrome. Now, this is a very long name, I think, for something that we as surgeons recognize easily as feeling like the chamber has deepened. We see the iris move back and everything feels further away. The patient feels some mild discomfort but doesn't always tell you anything about it. It's something we can easily address just by breaking that lens iris bond. And if you just place your second instrument under the iris, lift up a small amount, it re-equilibrates the chambers and gets everything to resume back to normal. But it's something you want to think about because it might happen multiple times, especially every time you insert your phaco device or the INA and it starts the irrigation. That's what could create that difference in your segments. I like to call the second one a long distance rhexis. These anterior chambers are larger, and once you've loaded the chamber with a viscoelastic to help flatten the lens might feel very far from your wound. You might feel that your forceps or your cystotome, whatever you use for your rhexis, is reaching very far, especially at the far end of it. You want to make sure that you plan the size of your rhexis accordingly to make sure you have an adequate sized rhexis for surgery as well as lens placement without running the risk of going so far away that you lose control on the rhexis and have the chance of it running out to the equator. You also don't want to lose control and have your rhexis be so large that it has no overlap with your lens optic. Because if we want to create the best effective lens position, we want a full overlap of the capsular rhexis with the optic of the lens. Some of these patients, we tend to see difficult wound closure with these myopic corneas. You can hydrate the cornea and it might seem watertight, but the eye is so large that you need to hydrate the eye a little more to make sure that that wound actually resists leakage. If you're a younger surgeon, newer surgeon working on your wound construction, I highly recommend making sure you almost overinflate the eye towards the end and use a Wexel sponge or another type of drying device to make sure your wound is watertight and then releasing some of the pressure from your paracentesis to make the eye at a physiologic pressure prior to ending surgery. Postoperatively, you always want to make sure that you've examined these patients with a dilated exam. They're already at high risk for retinal detachment with tears and holes. And cataract surgery can induce subsequent tears or it can enlarge pre-existing tears. So make sure you ruled out a retinal tear and the risk for retinal detachment in the postoperative period. Now, this patient I mentioned had a staphyloma. That is something that would absolutely affect lens considerations because of the shape of the macula. So the following question ties into it. So what about lenses that are less than 6 diopters? Not everyone makes a lens that low, and so you need to find special lenses or certain lenses that are made in powers that low, as was suggested for this patient. With the extended depth of focus lenses and the multifocal lenses, we rely on a very standardized macula and foveal anatomy. to get the precise optics to come to the same point on the fovea and give the patient that extended range. If the staphyloma has changed the anatomy of the of the macula and the fovea, then we can't rely on these lenses to provide the same level of vision for this patient that you would promise another patient with a healthy, normal fovea and macula. So I would not recommend using an extended depth of focus or multifocal lens in this patient. This patient was requesting a refractive outcome, and my suggestion is to use a light adjustable lens in this patient that we can help adjust as close as possible to their desired outcome and educate the patient that they are outside the normal limits of most lenses. The LAL has two types of lenses. There's a standard and a plus. The standard comes down to about 6 diopters, but the plus comes down lower. And you might be tempted to choose the plus lens because the biometry is closer and it shows a closer to zero plano outcome. I would not recommend falling into this trap. The LAL Plus is also an extended depth of focus lens. This is a light adjustable lens if you're not familiar with the abbreviation. The plus is extended depth of focus and again would fall into that trap of not delivering the correct amount of depth and focus to that altered foveal anatomy. However, the standard is a monofocal adjustable lens. And so, despite it ending up more myopic because it has a stronger power lens, I would adjust it in the postoperative period to get closer to the desired outcome for that patient while still having monofocal quality vision for a staphyloma. All right. So our next case is quite the opposite of that 33 millimeter eye. This is a large lens and a small chamber, which is very common in my part of the country here. This is a 72-year-old lady who came in with 3 plus nuclear sclerosis. Her biometry showed that she had an axial length of 22.53. This is getting closer to the short end of the range of eyes. The lens thickness was 4.88, which is larger than average, and an aqueous depth, not an anterior chamber depth, an aqueous depth of 1.72 millimeters. The reason I highlight the aqueous depth is that this is the area we're going to work in, and this gives us an idea of how much room is left in that chamber. Her cup to disc ratio, interestingly, was 0.75 in that eye, and the other eye was 0.3. Pressure was normal in both eyes. So based on this presentation, can we make any assumptions about prior eye history? Is there anything she might be experiencing or the eye might be undergoing physiologically at home that could affect our cataract surgery? And what intraoperative issues should we plan for in this eye, contrary to a large myopic eye? With those issues in mind, is there anything that we can modify about our surgical technique? And are there other suggestions that we might have to make this surgery better for the patient and better for me, better for you, the surgeon? So we've already established she has a larger than average, dense cataract. She has a small chamber and this asymmetric increased cupping in that eye. Likely, she has been experiencing intermittent angle closure. Perhaps when she bends over to pick up things, or if she's prone for anything, the lens might be moving forward and closing the angle, causing an increase in pressure, leading to cupping, and then it resolves when she is supine or just not dependent on the eyes. With intermittent angle closure, we can see hypoxia to the iris and the zonules. This can affect their behavior during surgery. We need to account for these changes because these can make or break your surgery depending on appropriate planning. You may also experience aqueous misdirection. I will tell you that in this patient, despite my planning, it's still, I experienced many of these issues. And so it's important to plan to try to prevent these issues, but also to plan to resolve the issues intraoperatively. When you make your wound, if possible, have a slightly longer wound than your average wound. It still needs to have good construction. We don't want it to be so long that we're changing the corneal astigmatism, but slightly longer so that if the iris is trying to prolapse, it's going to be more difficult for it to come through a longer wound, and it might just stay in the eye instead, making your surgery significantly easier and helping your postoperative outcomes as well. Do you want to use iris hooks or an expansion ring? This might help hold the iris and prevent it from prolapsing as well. We should plan to have capsule hooks and a capsular tension ring. Given that there has probably been hypoxia to the zonules, we need to be ready in case of zonular dehiscence or instability that need these instruments to help us get the lens out safely. Now, earlier we were talking about lens iris diaphragm retropulsion syndrome. This is a place where we also need to pay attention to the anterior chamber depth and the intraocular pressure because if we experience aqueous misdirection, the irrigation from our surgery might be going behind the iris through the weak zonules and into the vitreous. The patient typically doesn't complain or feel pain with this. Your eye does not become rock hard, but your chamber becomes very shallow. And it's not safe to work with this prolapsing iris and a shallow chamber and a large lens coming up. You might not be able to fit your instruments back in to the anterior chamber when this happens. You're considering suprachoroidal hemorrhage, choroidal effusions, all things that we consider in short eyes, but the clinical scenario does not match. You have to remember aqueous misdirection could have occurred during your surgery. And an intraoperative vitreous paracentesis can help decompress that hydrated vitreous, give you the space you need to finish the surgery and get out of there. A retrobulbar block would also be something to make the patient more comfortable for surgery. With all of these issues we see and plan for, this surgery might take longer than normal. And if the patient starts becoming uncomfortable and you might start to experience posterior pressure if they start squeezing out of discomfort, which is the exact opposite of what you want when you're dealing with a small chamber and all of these risks. So that block might make the surgery easier for you and for the patient. Okay, so our final case, I'm just trying to go a little bit more quickly. I know I was taking a little long on time. So the last case is the exact opposite of our very long eye. This is a short eye with nanophthalmos. This was a 27-year-old male who came to me for a LASIK evaluation. He actually had 12.75 diopters of hyperopia, and his biometry revealed an axial length of 16.57 millimeters. Um, to date, that's perhaps the smallest axial length that I have seen in any surgery videos or heard from other colleagues. His aqueous depth was 2.73. So this is important because we talked about anterior chamber depth and aqueous depth affecting our surgical outcomes. This is a very small eye. This is about 6 millimeters shorter than the last eye we talked about. Yet the aqueous depth is almost a full millimeter larger than that last patient. Our anterior segment anatomy is much more normal, despite our posterior segment being significantly smaller. So these are why these variables are so important to incorporate into biometry. This patient had a normal interocular pressure. So, in an eye like this that is extremely short, what formulas can we consider and what can we use? How do we manage the risk of choroidal effusions and malignant glaucoma? This eye is much more at risk. It's even smaller than the last eye. And are there specific lens types or surgical techniques that we prefer in non-ophthalmic eyes? Once we've discussed that, I'd like to see what is our surgical approach as a group. We have a very large group here. I'd like to just see what we think. So first poll is which formula should we prioritize for an axial length less than 22 millimeters? This is a screenshot of the biometry from our Anterion device, as well as the pictures you saw before that had the anterior segment OCT, the corneal topography, the picture of the eye, and all the measurements. The EVO formula is choice A. The Kane formula is choice B. The C is the Barrett formula, and D is Holiday 1. So which one is your best choice out of all of these? These are all great formulas. Okay. I love it. We are almost perfectly split. We have a 20% for the Evo, 24% for Kane, 31% for Barrett, and 25% for Holiday 1. So the third generation formulas, the Evo, the Kane, and the Barrett, these are the three formulas that I use for every case. I look at them no matter what for every case I have. And when do I choose a certain formula when I have these patients with axial length less than 22? They all have phenomenal outcomes. There is a study presented on the Kane Formulas website that shows very slight increase in better outcomes, very slight, better outcomes than Barrett in that study. Otherwise, most studies show them to be quite similar. So while I encourage you to look at multiple formulas, um, I will look at these three and then I will veer towards the cane to break a debate between the three formulas because that's going to be my stronger one. But typically, these three do agree. But I would recommend looking at that for your very short eyes to help break any tie breaks. All right, and now for our final poll question. This is the other half of that screenshot from my biometry, a picture of the biometry that shows you if you obtain good measurements, keratometry, and the anterior segment OCT. How are you going to do surgery on this patient? Are we going to go in together with the retina specialist and do a vitrectomy first to help decompress the eye, reduce risk for effusions and hemorrhage, and give you more room to work? Are you going to refer this to your senior partner because I have no idea how to do this surgery and maybe they do? Are you confident and you say, I can do this surgery myself? I learned everything I needed to know from this webinar and I'm good to go? Or D, do we talk to the patient about considering holding off on surgery at this time? Okay. All right. So 58% combined case with retina. Do a vitrectomy first. 22% referring to your senior partner. 10% of you are ready. You are ready to go to do the surgery. and 10% of you said, let's talk about non-operative management. I love this because I love to see the distribution amongst everyone, and I'll tell you what I did. In my mind, I agreed with the majority of you, and I said, let's try a combined case with retina. Let's have them do the vitrectomy first. I think this will give me a great surgery. I think we can handle it. Let's prevent angle closure glaucoma later on in this patient with an anophthalmic eye. Um, and this is me as an anterior segment surgeon speaking. So I consulted with my retina doc. He's a great surgeon. We've operated together on a couple cases before. And he actually taught me something from the retina side that in this young patient, 27 years old, with the type of vitreous he has, that going into surgery at this point from a retina perspective would actually be quite high risk and not indicated for this patient for risk of retinal tears and detachments in someone who is at their baseline vision with normal pressure who was just seeking refractive elective surgery. So in reality, we ended up going with choice D, and I will elaborate. But let's go through those initial questions first. So choosing formulas such as the cane or the Barrett that are optimized for short eyes would be recommended, as I explained earlier. Intraoperative issues. So we want to prevent pupillary block and malignant glaucoma, considering a prophylactic iridozonulohyalotomy. So I talked to Dr. Manjul Shah a lot about this, and he gave me some great advice. And he said, use the vitrector, make a small hole in the iris, go through that hole through your zonules on the cut setting, and make a small cut into the vitreous at that point, and that will very much help you during the surgery and afterwards. If we are concerned about choroidal effusions, then we can consider making scleral windows. So if you are comfortable with those, I would highly recommend them. And if not, then consider help from another colleague to start learning them. And that way you can do these cases a little more safer. When it comes to lens selection, we have to consider the upper limits of intraocular lenses. So in the US, the strongest lens we can get is a 40 diopter lens. And if we want to go higher, we have to order them custom from Europe or somewhere else. This patient's measurements yielded a 45 diopter lens. So a couple of things to think about. Should we do a piggyback? Should I just get a 40 diopter lens and then piggyback on a lens to make up the difference? Should I just custom order a lens internationally that meets the 45? Is the 45 diopter lens going to be too thick to fit in this small eye? Or should I just do a 40 diopter lens and have the patient use glasses, and let's be happy we've reduced the magnitude of the hyperopia almost 10 diopters. We also want to consider the intraoperative fluidics management. This is what I had talked about earlier with watching out for the fluid going behind the iris through the zonules and hydrating the vitreous, closing your chamber. Lastly, we want to remember to do no harm. The patient was at baseline vision at 2050. You can understand he had some baseline amblyopia given that high prescription. He had normal pressure. So all I was treating, if we were to go through with surgery, was just a desire to reduce glasses prescription. The amount of risk we would undertake with this surgery for that outcome is perhaps too much risk for this patient. But in the future, if we start having a risk of glaucoma or cataracts blocking the vision, then I would definitely agree with surgical approach that the vast majority of you guys chose. Okay. So I'm gonna try to open up the Q&A now so I can read what you guys have been asking. Okay. I think a few. I'm just gonna go from most recent and let's see. Okay, I can answer some of these pretty quick. Um, if there's refractive surprise, what is the stepwise approach to find the reason for the unplanned result? I think that's a great question for this lecture. Um, I've had refractive surprise in some cases. So do we uh, we need do we measure the biometry again? Let's get an auto refraction. Let's find out where the lens is positioned. Let's see, get an OCT of the macula. Did something happen that has changed the macular position? Let's get a topography. Let's see, is there just too much astigmatism from my wound? Did I hydrate too much and it's changed the corneal shape? So addressing each of these major factors, right? Axial length, our heaviest factor. Did we calculate it correctly? Did I use the wrong patient's axial length? That would be the biggest reason for a refractive surprise. Did we change the axial length because now the macula is detached, or has an effusion or subretinal fluid? Um, Did the cornea change? That's affecting the biometry significantly. And then is the lens where it's supposed to be? If we can get the biometry, we can find out if the lens is perhaps too far back, is there viscoelastic retained in the capsule? These are the options I would suggest for finding out why there's refractive surprise. SRKT versus Barrett and extreme myopia. We still have better data in the Barrett versus the SRKT. Um, I am trying to remember off the top of my head that the Wayne-Cook adjustment, I believe, is also used for the SRKT formula. So by itself, I would use the Barrett over that formula. This one, three formulas, I already mentioned the Evo, Kane, and Barrett are my three that I like to use. How do you predict and manage the lens iris retropulsion syndrome? I talked about managing it. We just want to lift the iris up with a second instrument to re-equilibrate. Um, and as far as prediction, it's more likely to happen in these high myopic patients. I would not recommend a CTR prophylactically in myopic eyes unless you see zonular dehiscence during surgery. You want to make sure you have enough clock hours to warrant putting a capsular tension ring in. If you just have maybe 1 hour, you can put the lens haptic in that area to help stabilize the capsule in that area. But over 3 hours, we want to start considering capsular tension rings. And more than that, maybe 6 hours, start considering capsular tension segments. I do not recommend multifocal IOLs in extreme myopia for the same reasons I discussed earlier, where the macular pathology is a stretching effect. If you have a totally normal fovea macula in that patient, I would say go for it. Rexus size in the myopic patient. We still want to aim for 5.5 millimeters. I'm sure everybody watches Cataract Coach. He talks about it ad nauseum that 5.5 millimeters is going to give you a great overlap with the optic. Why is Barrett more reliable than the others? I think these formulas are all very reliable. It's just that when we compare data with outcomes, Barrett is the closest compared to many of those. And that's just based on the formula dynamics, the data that's collected. It's always evolving and getting better with time. Can we leave it if I am, sorry, I'm not sure which case that would be. I would always try to put a lens in if possible, if safe. Either put a sulcus lens if you need to, or having a bicameral eye will be a little safer for that patient long term if possible. All right, let's see. Let's find some. Okay, I did mention hyperinflation of the eye to ensure no wound leak. Um, if you remember, during surgery, the eye is also hyperinflated. So the eye is okay with that high pressure for a small amount of time. When we do intravitreal injections for retina, the eye goes to a high pressure for a small amount of time. So you are intra-op and you can directly control the pressure. When you're hyperinflating, the eye is going to be hard. You'll feel it. When you push with your cannula, there'll be resistance back. If your wound is not leaking right then, you already know your answer and you can just depress your paracentesis and equilibrate that pressure. that eye might have been at a high pressure for 5 seconds. Um, someone asked about leaving residual myopia in the high myop patients. This is something that was taught to me in training as well. Um, what I have learned over time is that it's a question to ask the patients. I will discuss that with any of my high myopes. I will tell them, you are used to seeing without glasses up close. You're used to reading without glasses, but you always had to use glasses to see far away. I can make it so that you will still read up close and need glasses for far away, or I can aim to get as clear far away as possible and you will wear reading glasses. And we have that conversation, and it's made things less stressful for me because the patients just tell me what they want. And if I'm looking at a calculation where perhaps my two lenses are a plus zero point 0.1 and a minus 25, in a hyperopic patient, I would lean to the zero point 0.1. That's usually my upper limit. But in this high myop, okay, in that case, I'm going to choose the minus a quarter instead. Okay, yes. Thank you. Someone answer this question for me on the AC depth and aqueous depth. Okay, yes, I'm very glad this question was asked because I wanted to address it. If the patient has silicone oil needing immediate cataract surgery, would you do biometry before or after silicone oil removal? Or what if the cataract is needed to be done along with the silicone oil removal? This is a great question. I love this. This is the important. We need to know why does silicone oil change biometry? If you have a newer biometer, you can actually select silicone oil in the eye. Silicone oil changes the speed of light and sound compared to vitreous. The refractive index is higher, so the speed is slower. That would lead to a falsely long axial length measurement in these patients with older biometers. So accounting for that with the newer ones or mathematically accounting for it with a older one would be useful to figure out the lens power to be used. Now, is the silicone oil going to stay in the eye or is it leaving the eye? Because when I do the measurement, I need to put what media is in the eye. Is there vitreous or silicone oil? Now I have all my measurements. I have the axial length. I have, um, I have all like cornea, everything we've discussed. But is this eye still going to have oil in it 5 years from now? Or are we going to remove the oil and end up with aqueous or vitreous in the back? That's going to affect my lens selection. Remember that silicone oil staying in a phakic or pseudophakic eye acts as a diverging lens. It has a a concave surface on the posterior surface of the lens. So you would need to add a stronger power lens to make up for the silicone oil diverging those rays of light. Whereas if the silicone oil is to be removed, you would proceed with your normal lens that you would put in an eye with those measurements. And so that would help. It's important to have these conversations with the patient. I think everything I just gave you is a very academic answer to all of that. I do want to add in a little more pragmatic, realistic part of that is if a patient has silicone oil in their eye, there's a reason. It wasn't just for fun. They have some severe retinal pathology. When we're looking at these lens options, we find it easy to get obsessed with quarter diopter changes and minutia. Some of these patients will see that well to be able to appreciate those changes, but many of those patients might have proliferative vitreoretinopathy. That's why they needed the oil, or they've had three retinal detachments. And their macula might not be functioning at the level to appreciate even half to full diopter changes. And so that can help take some stress off of you and discuss that with the patient with your outcomes. Contact lens for the third case. I absolutely suggested that. The patient just told me no. He said he couldn't tolerate contact lenses at all. biometry for post-LASIK eyes, we mentioned with Barrett-Truquet or the Asker's post-refractive formula. Okay. Oh, this is nice. Okay. What emerging advancements in IOL power calculation and biometry do you believe will have the greatest impact on improving outcomes in complex cataract surgery over the next decade? There are already people working on such accurate measurements of the eye. I've been fortunate enough to try out this Oculix formula on the Anterion as it's been moving forward. The goal is to essentially recreate the eye in a computerized form with the amount of data we can obtain. And essentially in the computer, simulate, put the lens in, simulate the surgery, put the lens in the eye, figure out where it heals with the effective lens position, and then refract that eye all on the computer. And then figure out what's the prescription going to be. And then that will help us choose the correct lens. What's the best A constant? What's the best company lens to put in this patient to get the closest to plano or desired outcome? I am very excited for that when it comes to fruition. Managing refractive surprises in post-corneal transplant eyes is certainly quite challenging. There, I had a patient where we were anticipating needing a DSEK because his corneas were very weak. His endothelium was quite weak. And his other eye took a very long time to heal from surgery. I was anticipating a DSEK in the other eye, so I actually targeted about a -1. When it comes to a monofocal lens, you can just aim a little more myopic if you're planning a DSEK, or likely they're going to need it. But again, counseling the patients and discussing that there is multiple areas of pathology, and with a monofocal lens, um, there are limitations. We're already anticipating needing glasses, and if they're okay with that, that can help mitigate the surprise there. And if the patient is very demanding of having that perfect outcome without a second surgery, that's where something like the adjustable lens comes into play, where you can put the lens in, have it stabilize, then do the DSEK, have it stabilize, and then do the adjustments. Let's see. I think some of these are similar questions. In a setup, so this is good. So in a setting where you don't have retina on site, how should we handle small nanophthalmic or extreme myopic eyes for cataract surgery? Do we do it modified or do we refer out? I think this is a very important consideration. In a patient who's a myope, who extreme myope, high risk of retinal detachment, is this patient going to be able to have retina surgery if they need it? And if the answer is no, then let's have that discussion with the patient to find somewhere where there is retina and let's have the cataract surgery done there so that if anything happens, they can have surgery. Or maybe we do surgery locally and the patient can go over there for the healing period to make sure that they're safe. Having that discussion with the patient because it's access. If it's, for example, you have to travel 7 to 10 hours to get a retina consult and the patient is just not willing to do that, it is a very important discussion to have with them. For the non-ophthalmic eye, similarly, um, if they have a suprachoroidal hemorrhage that needs immediate urgent retina attention, it's very important to have that discussion. If there's retina an hour away, for example, something that's feasible and the patient understands they're willing to go get that, and they'd rather have you do the surgery, I think it's totally fine to proceed with the precautions. You know how to manage these cases. I have retina here, not in my practice, but we can do the surgery, and then worst case, if they need retina, we can get them in quickly. Okay, I think I have time for maybe one or two more questions. Let me just look through these. Okay, so someone asked about retrobulbar blocks carrying a risk of globe perforation in the long axial length eyes, and general anesthesia is often unavailable. In a patient, if you need some sort of anesthesia with a block in these long axial length eyes, when you are intra-op, if you just make a small incision inferiorly in the conjunctiva, and then just dissect to get into the subtenon space, you can take a cannula, a blunt cannula, and put your block solution subtenons as far as you can go back, and that will help achieve a large degree of akinesia for that patient without risking a sharp needle going in blind and perforating that eye. Okay, post-RK patients, the Barrett-Truquet also works on post-RK patients. In cases of anisometropia, um, the IOL is going to change the prescription closer to emetropia, so you can still use the same IOL in both eyes. And then let's see, very last question, end on time. Here in our facility, a patient has to undergo refraction only a few days after cataract surgery. How do I know what the result that he got the right IOL for my biometry calculations? This is quite challenging. I mean, if you were able to do the surgery with very limited energy and healing, even if the cornea was perfectly clear on day one, the effective lens position is not there yet. The capsular bag still has to contract and scar, which will lead to the lens moving positions from where you ended it in just the first few days. And so, uh, I'm not really sure you'll know if it's the exact right lens unless it's so far off. You know, if your cornea has no edema and the patient's 7 diopters off, it's probably the wrong lens. Um, Typically, you do have to wait for the cornea to heal and to get a little bit of lens scarring. So even a week or 2 weeks to get a better idea of if that lens is far off. But if you're looking for something more of, is it a quarter diopter off or is it a half diopter off? I would recommend waiting until at least a month for that refractive stabilization. So I want to thank everyone for joining me this morning. I hope this was educational and I hope we learned a lot. I would love to answer all the questions if I could, but I know we are time limited. So thank you again for your time and your attention.